Welcome to this overview of the clinical features of Parkinsonism designed for postgraduate residents. It is important to first understand that Parkinsonism is a clinical syndrome characterized by core motor features. It can have various underlying causes, including idiopathic Parkinson's disease, atypical Parkinsonian syndromes, and secondary causes such as specific medications. The core motor signs of Parkinsonism can be easily remembered using the acronym TRAP. The T stands for tremor. This is typically a resting tremor with a pill-rolling quality, usually occurring at a frequency of 4 to 6 Hz, and is often asymmetrical in its presentation. The R stands for rigidity, which manifests as increased muscle tone, often described as having a cogwheel or lead pipe quality during passive range of motion. The A stands for akinesia or bradykinesia, which refers to a slowness of movement. Patients will frequently exhibit difficulty initiating movements alongside a decreased amplitude in their actions. Finally, the P stands for postural instability. Autonomic dysfunction can present as orthostatic hypotension, chronic constipation, and urinary dysfunction. Sleep disorders are highly prevalent, particularly rapid eye movement sleep behavior disorder, severe insomnia, and excessive daytime sleepiness. You must also screen for cognitive and psychiatric issues, which can include executive dysfunction, frank dementia, clinical depression, anxiety, and sometimes visual hallucinations or delusions. Additionally, sensory symptoms like hyposmia or diminished sense of smell, unexplained pain, and general fatigue are frequently reported. Finally, let us discuss some crucial clinical pearls and red flags. The presence of red flags should immediately raise your suspicion for atypical Parkinsonism rather than idiopathic Parkinson's disease. These warning signs include early severe postural instability, early falls, early severe autonomic failure, supranuclear gaze palsy, a symmetrical onset of symptoms, rapid disease progression, and a notably poor response to levodopa therapy. When differentiating these syndromes, look closely for specific atypical features that might point to conditions like progressive supranuclear palsy, multiple system atrophy, or corticobasal syndrome. For your general clinical practice, always ensure you perform a detailed neurological exam, consider administering a levodopa challenge test, take a very careful history specifically looking for drug-induced Parkinsonism, and systematically exclude other potential structural or metabolic causes.